Global Aphasia Treatment by Kylie, Junga, and Pamela Schue. We're going to start by talking about some background information.
We're going to start with prognosis. The prognosis for global aphasia and for recovery of premorbid speech and language abilities is poor. Individuals make significant improvements in communication skills with treatment during the first year post-onset. The largest percentage of patients with aphasia referred for speech and language services is mainly composed of those who have been diagnosed with global aphasia.
Global aphasia may be one of the most frequently occurring types of aphasia. Incident rates are between 10 and 41% of some people, and some others have reported it as high as 55%.
Age and sex. There are discrepancies regarding age and global aphasia. Some studies suggest that age does not affect global aphasia, whereas others report differences in findings of patients with Broca's aphasia, because Broca's aphasia patients tend to be younger than those with global aphasia. There are no observable differences in the distribution of global aphasia in regards to gender. Age and sex may not be considered as a differential diagnosis or effect on incidence of global aphasia.
Global aphasia can be caused by lesions in the cerebrovascular area, including Broca's area and Wernicke's area. Broca's in the posterior frontal and Wernicke's in the superior temporal areas, pre-Rolandic and post-Rolandic speech areas. Also, large lesions extending from the cortical surface inferiorly to subcortical areas such as the basal ganglia, internal capsule, and thalamus may also be involved.
Language, cognition, and communication. The major marker of global aphasia is impaired language comprehension, with concomitant deficits in expressive abilities. Recent clinical evidence demonstrating preserved areas of language functioning in global aphasia suggests that the loss for these patients can be viewed even more. These patients have considerable single-word comprehension. They may also have recognition of specific word categories, familiar environmental sounds, and famous personal names. It has been found that patients with global aphasia have relatively better comprehension for personally relevant information. A specific relationship exists in global aphasia between cognitive nonverbal impairment and the breakdown of semantic lexical level of integration in language. With patients who have global aphasia, informative communication is needed rather than the use of prosodic elements or less functional means. They are usually most severely impaired in their expressive language abilities.
Next, we're going to be talking about treatment approaches in global aphasia. The conversational output of individuals with global aphasia consists primarily of stereotypic short utterances. Productive use of single words or phrases may not be a true realistic goal for some of our patients. The greatest emphasis should be put on improving not just communication, but the overall quality of life for these patients. Treatment may emphasize functional approaches, social approaches, or impairment-based approaches. Functional and social approaches use strategies to reveal a patient's residual linguistic and non-linguistic cognitive skills to increase successful communication. These are done primarily during the chronic phase of recovery. Impairment-based approaches use structured methods that are carefully controlled for levels of difficulty to provide a context that will facilitate successful language responses and shape succeeding language behaviors of increasing complexity.
Now we're going to discuss auditory comprehension. Auditory comprehension is a realistic goal for treatment. We aim to improve auditory comprehension using supplemented contextual cues, permitting consistent comprehension of one-step commands. Picture matching can also be used as a clinical tool. In picture matching, the clinician will produce a name of the item to be matched, providing a basic level of auditory stimulation. Also, the complexity of the task may be increased as you go.
Marshall created an approach for auditory comprehension, which involves 4 phases. The first is eliciting responses. The second is eliciting differentiated responses. The third is eliciting appropriate responses. And the fourth is eliciting accurate responses. Phase 1. Focus on attending, pointing, and yes and no responding. Also, help patients express themselves through nodding of the head and facial expressions. It is also important to use questions and statements about personally relevant topics to the individual. This may be one of the best ways or the best way to elicit a response from the client. Phase 2. The clinician should accept and reinforce any responses different from previous responses for the given stimuli. This can include varied facial expressions, head nods, gestures, and stereotypic utterances. The clinician should look for a variety of responses from session to session during this phase. Phase 3. At the third phase, the client should be able to demonstrate appropriate responses with occasional accurate responses. The clinician should encourage these responses, whether they are correct or not. Stage 4. At this phase, the clinician will seek accurate responses. This can include verbal and nonverbal responses.
Now we're going to talk about verbal expression. During the acute and chronic phases of recovery, the clinician should use short-term attempts to establish or expand the client's verbal expression. The clinician can help by teaching the client to associate meaning with speech movements. When associating meaning with speech movements, the client can do this by showing fingers, pointing, gesturing, writing, or matching to confirm the meaning of successfully elicited verbalization. Conversations that are personally relevant will improve the client's performance as well. Clients are taught to produce a small repertoire of useful spoken words or spoken plus gestured responses. This should include at least giving one greeting, yes or no, a few proper names, single words that express important needs, and one or more phrases. Imitation can be used to initially establish these responses.
Another means of eliciting verbal expression is conversational prompting. This uses modeling, expansion, and feedback to develop verbal responses in conversational contexts. This technique can be useful for developing contextually appropriate communication for patients with global aphasia. Another is voluntary control of involuntary utterances. This technique helps turn stereotypic utterances into more productive utterances. Within this technique, words that are involuntarily and inappropriately produced are identified and then turned into targets for treatment. Sequence of activities to train words, oral reading, confrontation naming, and conversational usage. The overall goal is to establish a vocabulary between 200 and 300 words.
In verbal expression, we can also talk about transcranial magnetic stimulation, or TMS. This is a non-invasive procedure used to treat naming abilities. You can also use magnetic fields to generate electrical currents over discrete brain regions. The effect is neuronal depolarization that can excite or inhibit the cortex. In a study done by Nasser in 2005, the study showed that after this treatment, a patient's testing at 2 and 8 months post-treatment demonstrated moderate improvements on the Boston Naming Test and BDAE. Patients continued to improve in auditory comprehension and involuntary use of words and phrases.
Next, we will move on to functional approaches, and we will start with gestural. First is the American Indian Code, and it's adapted from Amerindian Sign. It's a gestural system based on concepts underlying words. It's concrete, pictographic, highly transmissible, easily learned, agrammatical, and generative. This can be used as an alternative means of communication and a facilitator of verbalization, but the reports of the effectiveness on this technique vary. Another is visual action therapy, or VAT. This uses gestures to reduce apraxia and improve patients' verbal expression or ability to use symbolic gestures as a means of communication. The authors state that this method produces improvements in areas of pantomime, auditory and reading comprehension, verbal repetition, and graphic copying. Some of the other gestural programs available are pantomime, gestures for yes and no, eye blink encoding, and pointing.
We can also use non-speech communication aids in functional approaches. These assist communication by non-electronic and electronic means. Non-electronic are transmission of messages by communication boards, manipulation of symbol sequences, and drawings. Electronics are computer aids, visual systems, or the CVIC. Another great functional approach are the use of communication boards. Communication boards vary in type and complexity. They contain personally relevant words and pictures, numbers, and alphabets. Of course, the client would need specific treatment for the effective use of the board. To do this, the clinician could present target items in isolation, then after a delay, and then among increasing the numbers of foils until a ceiling is obtained for the number of items contained on one board. The clinician can then add alternative boards containing specific domains such as family, work, or familiar objects. It is suggested that using remnant objects can help provide an individualized touch to the person's treatment. The use of bliss symbols and drawing boards are also very helpful in treatment.